Kidney disease is one of the main complications of diabetes. We know that about 20 to 30% of patients who've got diabetes are at risk of kidney damage. If we look at the numbers of patients who need a kidney machine in this country, about 1 in 4 patients on dialysis on a kidney machine have diabetes as their underlying disease. So the most important thing is to look at how we can delay the complications of diabetes, how we can delay kidney damage itself, and we can do this through good education, through good care and good management.
We like patients to be very involved in their care. We like them to understand the condition, so we spend quite a lot of time educating our patients, and we also involve them in their monitoring, either through testing their urine or testing their blood. We like them to report any side effects that they may be getting from medication. But most importantly, we like them to be involved in their self-care by looking after their diet, watching their weight and trying to reduce weight if that's necessary, and with regular exercise.
Education doesn't necessarily mean just giving information to patients. It's most importantly about a partnership between patients, nurses and doctors. So good education really means for patients themselves to come with knowledge about their condition so they can ask the appropriate questions when they come for consultation, and also for the GPs and the practice nurses and doctors and nurses working in hospital to have an understanding about what it means to have diabetes.
Don't forget to get some the oats for my breakfast. It started in 1990. I was extremely thirsty. I'd come in at night and drink sort of 4 pints of water. I knew there was something strange, so I took a urine test to the GP, and straight away they diagnosed diabetes.
In our practice, we have about 400 patients on our diabetic register. We offer every patient an annual review where they have a very full checkup with blood tests. We also try to offer everyone a review at the 6-month mark as well, and we'll be checking their blood pressure and check on their sugar control. Patients who have less good control we'll see more frequently, for example every 3 months. And of course the newly diagnosed patient we may be seeing every few weeks at the beginning.
The important thing about diabetes is that it's a condition that can be self-managed. We like patients to be informed, and it's very important that patients come to their appointments when requested. When they come to surgery, we like to ensure that they ask appropriate questions so that they feel that they're controlling their condition, and to also bring results of their blood tests, for example, which they've been taking at home.
I was advised, as far as kidney damage was concerned, that my diabetes would have to be well controlled, and long term can cause kidney damage and many other problems.
It's a degenerative disease, really. Once you've got it, you've got it. It's then whether you can regulate it that matters. I think I've regulated it quite reasonably. And my wife has helped with that, with getting the right sort of foods and that sort of thing.
About 3% of the population have diabetes, but it also depends on the ethnicity of the population, and in certain ethnic groups the percentage goes up to 8 or even 10%.
There are many complications of diabetes, unfortunately. There's a risk of cardiovascular problems, so problems to do with the heart. There are problems that potentially come with the feet and also with the eyes. So kidney disease is just one of the complications of diabetes.
The kidneys are the major organs which help us get rid of the toxins which are produced from what we eat and also our daily activities. Diabetes is a process in which the body produces a huge amount of sugar and struggles to get rid of it. One of the organs which tends to help flush out the sugar are the kidneys. So the kidneys are exposed to a huge amount of sugar, and as a result of that can get damaged in the process.
When the kidney damage is about 70%, so in other words when 30% function is left, quite often patients will be referred to a renal unit. When they come here they'll see a doctor or maybe even a nurse, and they'll start thinking a little bit about the possibilities if the kidney damage becomes severe. One of the early signs we see for patients who've got diabetes and early kidney damage is that they have small amounts of protein in the urine. We know as the kidney becomes more damaged that more and more protein is excreted from the body, and at the same time we see a rise in blood pressure.
I tend to ask people to think of the kidneys rather like a colander, and it helps you retain the things you need in your bloodstream, and the things that you need to get rid of go straight through the colander. Think of the holes in those colanders being affected by the sugar, and some of them becoming a little too large, and now things you ought to have retained begin to leak through the kidneys. Some of these things are called proteins. When we find diabetic patients with that, we know it's a marker that their kidneys have probably begun to be damaged.
Patients need to bring in a urine sample every year so we can identify which patients are at risk of kidney damage. The process is they bring in their sample to the GP surgery, and the sample is then sent off to the hospital laboratory. The laboratory at the hospital tests for two substances, albumin and creatinine, and works out a ratio between the two. An abnormal result for men is a ratio of more than 2.5, and an abnormal result for women is a ratio of more than 3.5. The result then gets sent back to the GP surgery, and then patients of course will have access to that result. It's very important that patients come regularly to have their blood pressure checked, because high blood pressure in itself can cause kidney damage.
Right. Mrs. Morris, your reading is 142 over 64. The top reading is slightly above what we aim for.
For most people, we'll be aiming for a blood pressure of less than 130, which is the top reading, over 80, which is the bottom reading. Although some individual patients may be advised different targets.
To find out whether you're taking your tablets.
I am, yes.
Which one are you taking?
Lisinopril.
Treatments for high blood pressure vary, but for people who have diabetes, there are certain groups of drugs which you find to be much more useful. These drugs are a class of drugs known as ACE inhibitors. You might hear the term used, and another close group of drugs called angiotensin receptor blockers. But I mention that only because you might hear it. In truth, the reason they're so useful is because not only do they treat blood pressure, but they also, by acting directly on the kidney, reduce the amount of protein that is leaking.
Have you any problems with that
No.
tablet? No. You should carry on with that tablets. Do you have any problems with the lisinopril? Any side effects
No,
at
I
all?
haven't had any.
One of the problems with some of these tablets is that they have side effects. For example, a troublesome cough. Sometimes people feel very unwell, have a headache, feel a bit faint. And the important thing for patients is to know that they must not stop taking them.
Most general practitioners and physicians who would be looking after you would want to try these tablets first, and only if you don't tolerate them, then think of others. But they have proven to be an extremely useful class of agents.
Monitoring blood sugar is just as important as monitoring blood pressure. We ask patients to monitor their blood sugars at home, and each patient will have an individual target.
Do you know the reason, or you probably do?
Not always, but very often you can relate.
Patients can monitor their own blood glucose levels using a meter which they can obtain from the pharmacist or from their local diabetes centre. These devices are very small, around about the size of a mobile phone. The monitor is very easy to use. The patient will just prick the skin using a tiny lancet, and only a tiny drop of blood is required. This is then put onto a test strip, which then goes into the meter, and it's able to tell the patient exactly what their blood glucose is at that time. Some patients will test maybe twice a day, but if a patient is on insulin, then they'll be testing more frequently than that, maybe 4 or even 6 times a day. The readings we get from the meters are pretty accurate, but you couldn't use that test as a diagnostic test, for example, and we need to have greater accuracy when we're looking at patients' results. In particular, we're able to offer them a test when they come to the clinic that looks at the overall control of their diabetes, and this test is called the HbA1c, and basically it looks at an average of the glucose over the last 3 months.
No, I'll do that with a little note.
Studies have shown that if patients have an HbA1c of 7% or below, that they have much fewer in the way of complications, and this is what we're aiming for when we're looking after our diabetic patients.
It's very important for patients to modify their lifestyle. Then there are 3 main messages. The first message is not to smoke. Smoking in itself can really damage the kidneys because it closes up the small blood vessels which are within the kidneys. The second point is about exercise. As with all diabetes, it's important to take regular exercise, even though it's maybe in short bursts. And the third point is about keeping your weight down. A GP or practice nurse will advise you on the ideal target weight, so it's very important that as far as possible you should keep to that weight.
Diabetic patients should avoid eating fatty foods, particularly animal fats or saturated fats, and also not too much in the way of red meat or protein, as protein tends to be very calorie dense. When it comes to talking about a healthy diet, we encourage them to eat a diet that is low in fat, not too high in protein, should have plenty of unrefined starchy foods and lots of fresh vegetables and fruit. We like them to avoid too much salt in the diet because of the effects that has on blood pressure.
I love my food. I've never worried about drink, so I've never had a problem with alcohol or smoking. But, you know, I've loved food and wrong quantities of it, so I've had to regulate that quite a bit. I found the dietitian very helpful in directing me in the early days of having diabetes.
Exercise is absolutely vital for a diabetic patient. It helps their insulin to work much more effectively because of what it does to your muscles. Even brisk walking for 30 minutes 5 times a week will really produce a lot of benefit for our diabetic patients.
Exercise is a big thing. I personally exercise as much as I can, mainly with swimming.
I've done a lot of cycling, walking, gardening, and now I'm retired. I go to the sports centre twice a week, 3 hours a morning, go into the gym, do a bit of exercise there, and then play games, mainly short tennis and table tennis, and that's really great fun.
I feel better, I feel healthier, and it does help with your blood sugar levels.
Smoking is disastrous for diabetic patients. It practically doubles their risk of cardiovascular disease and kidney disease and all the other complications of diabetes. We give a lot of smoking cessation advice, and we have one-to-one counselling for patients, and we're able to prescribe patches or medication to assist them to stop.
The most depressing thing about this, I find, is sometimes we are only involved in patients' care at a stage when it's almost too late. We end up with people who, as a result of diabetes and its complications on the kidney, now need to have dialysis. Sometimes this is because people haven't managed their diabetes very well, and in younger people who don't often give it the attention it deserves, it might be 10 years later you find complications have developed which could have been dealt with early.
Probably if I'd treated my diabetes better from the start and followed the diet and done as I was told more, it might have delayed the kidney damage.
It was an absolute shock. I went to my doctor with a bad back, and then they decided to do bloods, and it was the bloods that showed up that I was very, very anemic, and I was at near the end of disease, as they've told me.
I wasn't very good at following my diet. I had more children than was suggested that I should have. And I generally ignored diabetes. I didn't want it to overrule my life.
I was on a home dialysis, but it's not good for me.
I come in 3 times a week, and really it takes 3 whole days really, because you feel a bit dizzy and tired afterwards.
It has changed my life considerably, but after dialysis I feel a bit tired.
At the time that I was diagnosed, I was actually manager of a home for adults with learning difficulties and a staff team of 19. Obviously I had to hand my notice in because the kidney failure was so bad at that time. Since then I haven't worked.
Like a friend said to me the other night on the phone, "Oh, should we go away for a week with the kids?" And I said, "Oh yes, fine." And as soon as I put the phone down, I thought, "Oh no, I can't do that anymore."
So many things I used to do that now I don't do. But once I'm had my transplant, then hopefully it'll be all right.
Thankfully, some of these people would be able to have kidney transplants, but for quite a few of them, it's not only the kidney disease which is a problem, but other complications which might have arisen. It's therefore just so important, I think, that for a condition which is eminently manageable by the GP, the patients, and ourselves as kidney physicians, we should be doing all we can at different stages to make sure if this is going to affect the kidneys, it does so as slowly as possible.
I've worked in renal units for many years and looked after many patients with kidney disease caused by diabetes. I've often wondered whether some of the patients could have taken greater responsibility for their health, and in doing so had stopped some of the kidney damage.
I think the patient should probably be taking about 80 or 90% of the responsibility.
I personally feel it's 90% of the patient to control this. It's down to you. If you don't do it, well then these problems happen.
You've got to be responsible yourself for yourself, but if you are going to go to doctors and nurses and dietitians and other people, they are there to advise you and direct the way for you, and I've taken their advice very seriously.
Take this on as a challenge, something you can actually deal with. When you get to your GP, be asking, should I be on certain tablets for my blood pressure? What is my blood pressure? What is my blood sugar? Know these things, because you will find you can actually do a huge amount to help yourself rather than feeling helpless about this condition.